All right. I did record that, didn't I? Yeah, we're going. Okay. Remember this? This is where it's going to come back to haunt you. Okay, so we're going to go back and talk about the different areas of the lung. Because we want to drain specific areas, we're going to need to position the patient in a certain way.
I know about that one right there.
Yeah. This is a picture out of Butler just showing anterior and posterior views. There's another diagram of the same thing, but we're going to recognize that the area of how the bronchi, the segmental bronchi branch, we're going to use that to facilitate our positioning. So just some general terminology you should be aware of: supine and prone, and then the Fowler's, high Fowler's or semi-Fowler's. Trendelenburg is where, again, the bed is flat but the feet are elevated, and reverse Trendelenburg would be where the head is elevated in that fashion. It's kind of some pictures diagramming that exact thing. You can see here reverse Trendelenburg and Trendelenburg. And these are the positions that we're going to use. So we're going to use this, not what is in the lab manual. There also is, besides just simple positioning, we're going to use what is called percussion, not diagnostic, but therapeutic percussion. And it's basically a technique of clapping the chest to create energy to dislodge secretions in the hope that we can mobilize it. So while the patient is in these postural drainage positions, we can apply percussion to the chest. It's done by having a cupped hand and basically striking the chest wall in a rhythmic fashion. And the hope being is that vibrations are created, which are transmitted to the tracheobronchial tree. Certainly want to just some of the tips: remove jewelry so you're not beating the patient. Again, we're using cupped hands. We're going to use relaxed wrists and arms, and we're going to clap rhythmically over the area to be drained. Some of the areas to be avoided are obvious things like bony processes, breast tissue, bare skin. Don't want to compress over zippers. Why a patient would have a zipper on, I'm not entirely sure, but okay. We can also use, instead of our cupped hands, there are percussion cups that can be used. These are various sizes for various size children or adults. And then there's a pneumatic percussor that hooks up to a 50 psi line, oxygen or air, and the unit itself vibrates against the skin. And there's little ones for infants or bigger ones for adults. There's another example of one. So there's, other than your hands, there are mechanical ways we can accomplish the same thing.
When I was at clinicals, they were using simple masks. Like, instead of, they didn't have percussors, so they were just using simple masks. Not simple masks.
Resuscitation
masks. Yeah, sorry.
Yeah. So it's indicated when postural drainage is indicated and secretions are difficult to dislodge. Many times, simply positioning a patient will help drain that area. If it's thick secretions, then we may need to use percussion in addition. Some of the reasons we wouldn't use it: hemodynamic instability makes sense, rib cage trauma, hemoptysis. Read them there. And absolutely untreated pneumothorax. We've seen that one before with the intermittent positive pressure breathing. Another technique that can be done is what is called vibration, and as the name implies, it's nothing more than just vibrating the chest wall to mobilize secretions in the process. So here what we're doing is placing our hands on the chest and just literally vibrating the chest to try and mobilize and move stuff along. Same kind of general things we've talked about. We're going to, though, have the patient taking some deep breaths in, exhaling through pursed lips, and we're going to compress with a fine action during exhalation. And again, just as an adjunct to the postural breathing. Looking at rib cage and soft tissue trauma. Finally, we just want to talk about postural drainage because this is going to be the essence of what we're going to do for the performance evaluation. Our goal is to, again, get the secretions out that the patient is unable to mobilize and cough. The hope then is if I can get rid of some of the secretions, I can match perfusion with ventilation and get back to a normalized FRC. You can read the 4 major indications there. Somebody has a definitive problem that they cannot remove secretions without help. If they have a disease process that generates a large volume of secretions, like bronchiectasis or cystic fibrosis, 2 of the major ones. If they have atelectasis because of mucus plugging, or if they have a foreign body within the airway itself. Postural drainage is indicated. Again, we look at the contraindications as being relative benefit versus risk, and whether or not all positions are contraindicated, or just Trendelenburg or reverse Trendelenburg may be contraindicated. So here's some examples of where all positions may be contraindicated. Head and neck injury until they're stabilized. Hemodynamic instability, increased ICP. You can kind of look at them there. Where Trendelenburg may be contraindicated with the head down, certainly ICP, uncontrolled hypertension. And then reverse Trendelenburg, where the patient is hypotensive and can't tolerate having their head in an upright position. Some of the hazards that may occur during the therapy. And again, for hypoxemia, we can certainly start them on oxygen to be able to maintain a specific saturation. If it doesn't seem to work, contact the physician, see if there's some other alternative we can look at. Same thing is true with ICP being elevated. Some other hazards that are there and how to fix them. When in doubt, stop therapy and consult. Pain, or certainly trying to time it around pain medication if they're on a schedule. And then with vomiting and aspiration, obviously want to stop therapy and make sure the airway is patent. If they develop bronchospasm, giving a bronchodilator, common sense stuff. If we're seeing dysrhythmias, want to go ahead and stop and administer some oxygen. We want to verify improved breath sounds through auscultation. We're going to look at less work of breathing, hopefully, because of a good cough mechanism and mobilizing of secretions. Monitoring their vital signs. Should see an improvement in chest x-ray. And overall, the patient should be feeling much better because their oxygenation is improved. Stop it when the breath sounds are clear and the chest x-ray has shown resolution of whatever infiltrate was there, and there's no sign of infection, or when they become, so there's not a large amount of secretions that are being generated. So again, supplies that we need. Obviously a stethoscope, personal protective equipment, Want to look at the chest X-ray if there is one available. We're going to do, and this is the part of the performance evaluation that is going to be that you're going to have to understand, is adjusting the bed, adjusting pillows are necessary as needed for each of the positions. The percussion is indicated that we can go ahead and either use a manual percussor or our hands. Certainly, if they're on oxygen, we can monitor them with a pulse oximeter. And there are specialized beds that can be used, but we're not there. So as far as the critical life functions and scene survey, that goes with all the performance evaluations. We're going to review the chart specific to looking at the X-ray and the diagnosis. Look at any other precautions and contraindications. Obviously, as I mentioned, pain medications. I'm trying to time that, but also we're positioning them so that they can be at an increased risk of aspiration if it's right after a meal, so you want to time it around that process also. Standard precautions, identify what you're going to do to the patient, looking and interviewing them with our common, our pulmonary signs and symptoms, and then going ahead with our assessment of their organ systems. And we want to go ahead and use an assessment technique on a continuous basis, looking and making sure that they're not in a precarious position as we reposition them. Sometimes you're going to need to coordinate it around other therapy. Certainly, if you're going to do things like a bronchodilator, do the bronchodilator first, open up the airways, then go ahead and do the positioning. Usually the positions are for a few minutes. Sometimes they can't tolerate it that long, and you need to monitor them. And then we're end up doing it a couple, 4 or 5 times a day. So the goal is to place the lung segment you're trying to drain in a position superior to the carina, so it'll drain from that segment into the central airways. So these are the ones that we're going to end up using for the right lower lobe. I'm sorry, for the right lung, lower lobe. See where the various segments are. Left lung, left lower lobe, right lung, middle lobe, the upper lobe. I think the pictures are going to help you more. So that's what I would look for. So here we're looking at the anterior segments of the both lower lobes. So the bed is elevated. They're lying supine. Pillows under the knees. We would clap over the lower ribs. That's where we do percussion. Our second position is the right low lobe lateral segment. It's just a matter of rolling on the left side, pillows between the knees and under the head. We would percuss in this area. So that is being drained into the central airway. Both lower lobes posterior segments, again, the bed is elevated so that the head is down. They're lying prone, and we would then percuss over the lower ribs in that area. Lateral segment, also this position drains 2 different segments, both the right lower lobe medial segment and the left lower lobe lateral segment. It's the same exact positioning. Head is elevated so the feet are up, lying on their right side. Clap over the lower ribs, and in this case it's going to drain whatever is the dependent. This is what the left upper lobe lingula. They're lying on their right side with the left shoulder rolled back. I didn't name this, but some people call it the movie star or Hollywood position. Because you're like Cleopatra-like, I guess. And the right middle lobe is exactly the same thing, but instead the patient is lying on their left side with their right shoulder rolled back. both lower lobe superior segments. Bed is flat, they're lying prone. You're clapping over the mid-back below the scapula in that fashion. Right upper lobe posterior segment. Again, the bed is flat, they're prone, and we're clapping over the upper back. Right upper lobe anterior segment, bed flat, pillows under the knees, they're lying supine. Basically draining the anterior segment of the upper lobe. And the left upper lobe anterior segment, same idea, head of the bed elevated. They're lying on their back, pillows under the knees. And the apical segments are the easiest ones of all, the one you hope you get on your PE, because all you have to do is just sit up. Because you're draining the top. For this one, left upper lobe posterior segments, it's probably more easy for them to lean over than to lie in this goofy position. So most clinicians will end up just having them sitting on a bedside table leaning forward. So we're draining that posterior segment, the left upper lobe. So the performance evaluation, you're going to be asked to position the patient in 2 different drainage positions. Knowing how the patient should be positioned and where you should be, how the bed pillows need to be positioned, and then we'll go through asking you, if you were to percuss, where would you percuss? If you were to do vibration therapy, where would you do vibration therapy? To drain us two different lobes. I'm not going to show you any videos. So I will tell you that there are 3 of them that we will not do. I guess the apical segments won't be on there. They were the easy ones. But any of these other 4, 9, yeah. Any of the other 9 are fair game. Just a matter of memorization. No easy way around it. If you think about that tracheobronchial tree, and this is a good time to look at the models back here. Especially the actual tracheobronchial tree, you can see where that segment is positioned. And this is the chart that you'll need to complete. It's due April 20th, not 21st. Didn't change that. But that'll will give you the process for memorization. I'll post the answer key in Canvas so you'll have it. Just to double check yourself. And this is one that you definitely need to practice. Just talk briefly about pediatrics and neonates, because their chest is a whole lot smaller to deal with, and they're a little more difficult because they're not as cooperative. But the positioning is pretty much the same thing. This is looking at some of the left lower lobe anterior segments. Won't be dealing with infants for the PE, but they could be some questions related to that on the exam. Right and lower lobe lateral segment, again turned on their side. Right and left lower posterior segments, so they're lying on their belly, on your knees. Right middle lobe, lateral medial segments. And then the right and left lower superior segments lying flat.
I feel like we're trying to suffocate that baby.
Nah, we're not. They do well. And this is something that we would instruct mom and dad if the child has cystic fibrosis. A lot of times we would instruct them to do them when they're small and you can have them in your lap like that. Anterior segments, apical segments, again sitting up and draining. And there's the left upper lobe, again, similar to that leaning over the table or the leaning over the pillow. So here's an order. This is out of Egan, one of the mini clinic. He wants you to do postural drainage, percussion, and vibration 4 times a day until the chest x-ray clears. And this is in the right middle lobe. So we would need to position him so that we could end up draining that. one of the Hollywood physicians. 82-year-old woman with a history of osteoporosis, undergone thoracic surgery, large amounts of purulent secretions. What recommendations or modifications would you suggest? Well, the fact that she has the osteoporosis, we have to be a little bit more, percussion may not be indicated, however, postural drainage certainly can be indicated. While administering chest physical therapy, the patient's telemetry tracing begins to show a long run of VFib. Patient is stable with no signs of cyanosis or hypoxemia. Immediately stop the procedure and ECG returns to normal sinus. What could explain that? Well, the patient had got hypoxic. And that really should not be ventricular fibrillation. How about ventricular tachycardia? If they're in VFib, they're dead. Just saying. Chest physical therapy post-op craniotomy patient whose chart indicates the head of the bed must be elevated 30 degrees. We would then limit the number of positions we could place that patient in to be able to drain, because we don't want that bed to be positioned so that the ICP rises. 17-year-old girl with CF who has copious secretions, complains of dyspnea and mild cyanosis during positions in a Trendelenburg. Again, we can start her on oxygen. We can put a pulse oximeter on her to monitor her during the therapy. 25-year-old man with quadriplegia and tracheostomy. He's experiencing right middle lobe and right lower lobe atelectasis. Again, the positions, we would go back and take a look at what positions we would put him in. And because he's a quadriplegia, when we get to the talking about coughing mechanisms, there's different things that we can do to facilitate a larger breath and to facilitate a cough. Patients adequately cough spontaneously to postural drainage. What precaution must be taken with the patient? Always unable to do a good cough, and we'll talk about that when we get to cough techniques like that. I figured you should have breakfast in bed on your birthday. Can you reach the stove okay? Nice. Okay. If you want to pull out your PE on aerosol therapy, and I'll call it up on here, and let's go through what I'm expecting you to end up doing. This is next Tuesday and Wednesday. Okay. And inside your, who did not get a bag?
Well, that's what technical for Marine, we didn't have it.
All right. Who did not get one of these?
I don't know what's in it.
Inside there is a jet nebulizer that you can use practice with. Again,
Before or after high school?
Scrubs or business casual with a lab coat. If you have a stethoscope, bring it. If not, we'll find one for you for the duration. We want you to be able to go through the process of assessing the patient, which will be MRI. As far as the review the chart, we're not going to really have a chart here. However, you need to tell us what you would look for in the chart for the aerosol therapy. As far as an order, as far as any information that was done on a prior treatment, and diagnosis. Then coming into the room, explaining or go through the whole scene survey, primary survey. Why are you here? Who are you? How long will it take? Will it hurt? Make sure you wash your hands. Positioning of the patients, you want them in as high of a Fowler's as they can comfortably get. If they're a post-operative patient, talking to them and making sure they understand about splinted cough, so that because part of this process is we want to be able to get a cough. And then at the start, halfway through the therapy, and at the end. So 3 times you should be doing all of this information. Okay. Assessing them, heart rate, respiratory rate, breath sounds. If you are giving a bronchodilator, peak flows or FEV1 measurements. You should know in what point could this patient be doing some other kind of therapy as opposed to having a small volume nebulizer. What would qualify them or disqualify them from an MDI or DPI? Well, maybe they're comatose. Well, they can't do an MDI or a DPI. I'm stuck with an arrow. Maybe it's a pediatric patient who can't generate a high enough flow for a DPI. So we want you to at least have an understanding of why each of those different therapies could be used. As far as the preparing of the medication, we're only going to use normal saline, so there's not much preparation there. You open up the normal saline. And if you need to practice, better up here. Number 12 is an important one that you want to be able to. Amber and I will breathe exactly how you tell us to breathe. Okay? And if you tell us incorrectly, or if you don't tell us, so be it. Okay? The flow rate should be somewhere between 5 and 8. 6, 7 is usually a good number to begin the therapy with. And again, this is just talking about the monitoring of the patient in number 16, before, during, and after. Before, during, and after. Okay. Know what you should do if there's an adverse reaction. Amber and I will not have an adverse reaction, but you should know if we ask you how you would treat it. Again, while the therapy is going on, different things that you can instruct the patient on if they're unfamiliar with what their disease is or what their medications are. Once it's done, know that we don't use tap water to rinse it out. We use sterile water. We let it air dry. And then what's going to happen is you're going to do a documentation with a SOAP note. And this is should be in your folder also. We will give you a scenario, and after you're done with the treatment, you'll go ahead and document how that therapy went using a SOAP format. So it's kind of like your case study, but much, much shorter. Okay? And then, of course, there's the fair game questions that can either be asked during the PE or on an exam. Cool? Now, the pieces that are inside that bag, we have limited numbers on them. These are reusable. We reuse these. We sterilize, pasteurize them, and then reuse them. So please don't lose them. Miss Amber will be coming looking for you. Questions? Aren't you glad you didn't take an exam today? Yeah.
Thank you.
Thank you.
Are you gonna show me
How to set what? The nebulizer? Sure. Within your nebulizer bag, T-piece, flex tube. Should not touch the mouthpiece. Rather using the plastic of the bag. One end on there, the other end to your flow meter, turn 5 to 8. Allow it to nebulize. Patient should be pitched to the position so they're sitting upward. These nebulizers, most of them at least, are need to be in the upright position. If you have it like this, it's not going to work very well. Okay, let's hook up to a flow meter.
I didn't know if there's like a certain speed.
No, we're just going to use a wall.
Okay.
So using a nipple adapter, Christmas tree, whatever you want to call them, attach that, adjust the flow to 6 to 8. You can use air or oxygen, doesn't matter to us.
Where do you put that? Are you?
Just like that. Just squirt saline in there.
Yeah.
Typically, 3 milliliters of normal
So you don't even have to make it. Like a bureau.
No. Does Lori go through when she's talking about medications, about the unit doses? That they're already pre-mixed? Probably. Yeah, that's, and I'm sick of it. I don't know if patients do it. I can't feel a lot of it. I'm not eating. Questions? So you know all about this.
I'm gonna take this. That's my question. No,
Talk about the other things as far as DPI and MDI, because there's pieces there for both the therapy, and we have placebo MDIs for that. And then we'll also talk about the MDI and the DPI trainer as far as are we able to generate appropriate flow rates? Okay. I'll still watch quick when we direct. Or not.
So that's the most important part. So he
So
did
the
show
balance
us
of
what
time,
together with
we wanna go-
but this is the hardest piece. Like, we are like literally doing all this stuff. All the free stuff, you have to monitor people, you have to check the breath sound, all that good stuff.
Yeah.
That was not what's on everything. I didn't know that was part of what we were gonna need.
I feel like you guys
You need a bag though.
Listen.
And we can't leave, we gotta give back the gray part. Yeah, we're done.
You might get emails.
Don't take.
You might not.
I thought you were, we thought it was gonna be long. It ended up being not so long.
usually if there's a too close.
So this is gonna be on the stuff too. Position thing and stuff.
Not the position.
No,
But
that's
no, MDI stuff.
No, just so I can aerosol.
No, the MDI stuff's gonna be on the exam. We didn't talk about it. Yeah, we're doing that PE on Tuesday. That'll be on the exam, not the position. We went over testing the therapy. Yeah. That will not be on the exam, but it will.
Well, we're both for curveballs if you don't tell us.
No, I know, I understand. But are you gonna say like?
You showed us how to put together the here.
Yeah, just the narrative.
I'll just show it.
But what we may do is,
You put the saline in here,
Okay.
TP on top, glue to glue. This up the wall. Yeah, then I put the mouthpiece on one side.
Well, you don't hold it with your hand.
Obviously.
You put the plastic inside.
well, my patients have a tendency.
Have patients. Set the flow to 5 feet.
6 to 7 is.
I do.
And our meeting with Amber has been pushed to 1:30. Though the this plot has been shorter than expected, maybe we can get it under control right now. That's it.
Like albedo and all that, it all comes pre-mixed for the nebulizer.
In most cases,
Yeah, but sometimes they'll have to.
sometimes some medications you can get free. That's not free.
Right. Oh, we have to do a something afterwards. After we do it.
After,
Tuesday. Tuesday or Wednesday, depending on the day.
What now? I don't get what it's scheduled. I believe that's what the registration is.
I like it.
You asked.
Yeah,
I don't know.
Next year.
Are we just meeting at your house? What are we doing?
That's what you think.
I don't know.
So right now the plan was that I'm gonna go pick up Jesse and go back to my house. And since my house is on the way between Marie's house and the thing, we're going to. She's gonna meet at my house. I don't know where you live.
Oh, so that's right by me.
So,
That's right.
Well, if you're coming to get me, might as well get her on the way.
unreasonable.
I'll try to explain it. I just told her to.
I'm gonna be at just about 4, so somewhere around there.
You guys staying the night?
No, we're down it all in one evening.
The tubing that you put on there.
Are you going on Thursday?
I'm going on Thursday.
So I'll go with you because you have the biggest car. But we're going to, we're staying for the funeral.
Oh, what do you mean? Like, the car's gonna be like jam packed, like.
No. You stop talking. We're staying to after the funeral because we're staying to go church tomorrow. So yeah, we're not gonna probably get home until like 12. Maybe.
Okay, so I would take like.
You can only talk to me.
That's true.
Alright, we'll talk to you. I'll be right
All it is.
That's true. There is a dance with DJ John Anderson. DJ John Anderson gonna be there. Yes, DJ John Anderson. Literally the most Mormon name in the history of the world. John Anderson. I wonder if we can convince Rick to. What time does the class start tomorrow? Rick, can you text Amber to see if she'll come show us now? Thank you. So then I don't have to stay after 1:30 because I got somewhere to be at 3. He performs respiratory therapy conferences. He's big time, bro. He's big time now. You don't know about him. He's got an Irish hat. He's got an Irish hat. Sounded good.
Look like see.
Is this mine or is that mine? Sure.
Just
Yeah.
yesterday.
Ariana, wherever she's at, in there. I know, we're going to be now. Instead of talking about it, people start jumping on my bandwagon. I talked to Rick. Yeah, it said Rick. I told Rick that I invited Ariana. And now, like, coffee out. Okay, well, listen. This is how it goes down. This is who signed up for it. Me, Murray, Steve, and...
That's who I'm gonna do.
Okay, sounds good. Yeah. Oh, and I'm following you?
They're doing the high school tour. Oh, on Friday morning.
No, next week.
About one.
Discussion?
I'm out of it.
Like literally, they cut it down to 1 lane by hand, so I like got stuck.
By the way, I was being funny. I don't care that. No, yeah.
I know. You stay with her.
Listen,
Stay with her.
I've been part of the whole thing. I've been told that I've been rude today. Already like 2 times. So.
Oh, you've already made it before.
And and technically, and then I invited ourselves to let you drive us to the
Oh, you did. No. I offered.
I was like, listen, we should all drive with you because you have the biggest car. But then everybody was like, yeah, no, because you didn't want to stay. We want to stay before Steve.
But yeah,
Well, I do want to stop the brewery up there, so.
Oh, I'm down for some of that action.
And Bell's?
Cafe, right? Yeah, Bell's.
Yeah.
Cafe.
Yeah. I haven't been there yet, so.
Alright.
Since I'm there, I gotta have brewski. So, it all depends on how late it's getting.
Well-
I gotta wait for that brewski to wear off.
We have to go, like, between the conferences at 4:30, between both starts at 7:30, so we have, like, a good amount of time that we can probably all meet up and do some stuff. You have my number, right?
So that's Jesse's doing it.
Here. Be part of the solution.
If need be, I mean, I will.
Well, the thing here is just not saying.
The aorta coming out.
But see how I gave you my phone number and you were just like, no, I'm not cool enough to be part of your
This week.
Yeah, that just hooks up to the
Is that a?
yeah, it's a DPI.
Yeah.
Oh, it opens up. Well, this one doesn't, but it's supposed to they open like this. And then you put a cap in and yeah.
Oh, is this is that a placebo? Like,
Yeah.
a fake DPI?
Yeah, there's nothing in here. They're gonna put something in here to aerosol. That's why it looks like that. Yeah, that's a spacer. That's for your MDI.
This is the thing I've been asking you about.
Where's your MDI? You gotta have one.
You do?
No, he doesn't have one.
Literally does.
And we're told not to lose those or you're
You literally didn't grab me that.
Mhm.
So why don't you really do that?
This one didn't have an MDI in it.
What was the overall age?
This one didn't have an MDI in it.
What about this bag? Here, this one. Here.
Oh, is that maybe the one that you were using to show us? No. Yeah, so just grab that one.
Grab me the bag.
What else?
Yeah, I walked out. Something's wrong.
Oh.
So we're just doing this one.
And I did something bad. I did something bad.
Better explain it, dude. How they all.
Sort of walk out.
Yeah, explain how to do it.
Yeah, absolutely. They encounter invitation.
The wrong one.
Probably.
Yeah, we're explaining how to use them, we're not executing, we're only.
No, yeah. No, I'm thinking they're gonna be like, you put it in there, you actuate this, then they suck it, good, now works. That's it. It's not like a difficult process.
I don't know, because you only showed us the
The
one.
thing is like in there.
Well, MDI, don't you regret that?
No, not with the spacer. You actuate it in the spacer, and then you suck it. And then you don't suck too hard, or else it whistles.
And I have to suck as you're doing it in the case, otherwise it's gonna say doing it, it generates a little flow.
No, that's outside the spacer. Inside the spacer, because it's all gonna be trapped in here, and then you can suck it in, you don't suck it in too fast. No, it's not. This whole thing's gonna get so cemented that you can suck it in.
Hey, Amber, with the spacers in the MDI, you start the inhalation as then you actually, you don't have to.
Oh my
I
god!
didn't say that. She's saying
not like I don't have
You
alcohol.
don't have to because the medication.
It's gonna stay,
Yeah.
absolutely.
When you do it with the device that we test you guys on, it's a little bit simple, so you just gotta figure it out. But generally, that's why you use spacers is for the elderly or kids that just can't go have a coordination.
Right. All right, let's go. All right. Oh, Ariana, you got kicked. I'm sorry. You got released.
Definitely you can't be there. I'm just going to find out not that much. And you guys don't have that many students for. If you want to be there,
I'm
fine.
sorry.
Jason's on you.
I did. I invited her. I did 100% invite her. How's it going?
I'm just saying, like, how many people there are.
No, it's good.
I don't know where I'm getting more now.
Sorry. I didn't boot you. Amber booted you.
No.
No, I booted you. I booted you. Amber booted you. That's how it works.
I'm not booting you. I'm going with those that signed up. Alright. See now. Is it ready?
I'm worried about curing.
Oh, yeah.
Tried to say gas. The other 2 days.
Oh. Yeah.
Where were you?
Come out of here. Yeah, literally.
Right, exactly.
Alright,
Yeah.
let's do that.
Yeah, I'll be.
So apparently I have my shit together.
Maybe next year.
Okay, Sam, get on bed.
Right.
I can see that. Alright, you bring that.
That's the amount that man has to hold.
Amanda wants to clean that.
It was a little rough. That was easy. Yeah, that was an easy read.
Page 7, we done some more.
Rise. The pressure builds up.
Yeah, it's not, it has to be asked this week, so I know what the answer is.
Pressure is like.
Amanda's the leader.
I can't even get something as well.
This is like lifting to that.
The only other one that you have an option.
Okay. If I make the pressure higher,
Yeah, I think
what's gonna happen to the volume?
Alright. Need a little bit.
Lower.
We're doing a DTI. I don't know, let's figure out how to do it first. Oh, you want me to do that?
Now notice what also happens when I make
There's no
the pressure
medication.
lower. They shorten the eye time.
3 weeks. Because we do this on Tuesday and the
It's gonna be after the break.
What's gonna happen when I make it flow faster?
I just don't, I think that's what's on the
Yeah,
exam.
their mouth on there, no more. And then you
Like,
can.
I make
flow over that amount of inspiratory time. That's not going to be really well. It's slow.
Oh my God! It doesn't matter, my mouth always holds my breath.
My teeth showing. Alright.
You always don't want to have it. In that, it's 100% source. So unless I have this
Deep guy.
compressed air, actually it wouldn't matter if I had a compressor or whatever it is. When I pull this out, this right here is a mature signal. Okay.
Yeah,
So when it
okay.
gets to
I'm just trying,
the
actually,
air,
yeah, I can tell what these
delivered to the patient. Okay. The FiO2 comes very, it actually starts off at about
and then you have to check.
towards the end of the breath, it goes up to 90. Why? Because pressure is being felt, it goes up here as you go to breath. That increase in pressure in a venturi downstream, what happens to air entrainment during downstream pressure?
Okay, so no, she sucks at rapping.
Air entrainment goes down, so now you have less air being entrained, higher FiO2.
Yeah, look.
Just like on a jet nebulizer, downstream back pressure will cause the FiO2 to rise. We're not going to worry about the expiratory timer, but basically what that is, just as you guys know, if I turn that on, it's actually a backup. You can see it.
Put on the other end.
Yeah.
Back here.
Oh, and you need the medication.
Well, I mean, I'm just obviously.
And what it does, all it's doing is it's touching the clutch plate and moving it over.
Oh, so you need to go there. You just need to
Imagine I have this, and I have a cap that I put on this that has different size holes. So I can adjust it so that when the patient exhales, they exhale through a resistor with personal breathing, rather than
Why are we really putting this in?
Well, yeah, then you really want to.
that's for retard they talk about. You want to mimic
I have
that
those.
process.
And he told me, he told me now we can use them to
Talk
craft
about
them.
that when we talk about what's more muscle memory. Oh. Don't, it's the cycle, right? Leaks. Always leaks somewhere in the system. I can't reach my target pressure. If you see something where you,
Okay, it's on. So
Yeah, you just put it, it goes
Or-
around.
if the needle hangs there and doesn't rise, well, you should want this 2 to 3 times for spontaneous, like I want to have one expansion. And the inspiratory time should be something between 1 and 2 seconds, so that it feels comfortable.
Okay, that's all I have to do. Until the medication.
Watch the troubleshoot.
Yeah, because look how much more. Look all your.
But out. You call that sitting up in bed?
yeah.
Who's monitoring this there? Who's in charge of it?
Amanda?
Oh.
She doesn't know she's lying.
I didn't realize your everyone should be actually recording this, and I turned to look at your recording, I'm like, I don't know.
Right, ours is slow and you know.
You know.
Tired?
I don't know what airdrop is.
High followers are even better.
So, like,
I'm gonna have to show you.
I've had iPhone for like 5 months.
Think about it.
Yeah. I mean, I realize that about every week. So would it airdrop to everybody in your contact?
Set it up, just,
Wait, what about when it's airdrop kind
that's on the problem.
But can you send it to us?
You have to send it through an email or something like that. There's like an app you have to get for it.
I know, if you do it, so you said,
Airdrop.
so if you airdrop,
I thought we would have studied last night.
Go to your file. On your file. You can choose to send it to
airdrop it to you guys. Okay, what do I do?
Now go to your picture.
Did he?
Yeah.
Oh, okay, you're right.
So choose the airdrop. Your should pop up.
And then I was, that's not a signal, I'm pretty sure you were here that day.
Yeah. Oh, you gotta tell your airdrop.
Oh, that would be
That's so funny. Where do you vote? How do you do that? I
They do with the shutter, just like iPhone does. Yours is called something else. Like it's like
There we go.
But I was trying to get it to work.
So what do I do? Send it? So tap picture. Oh, thanks, Andrew. That's scary. Except airdrop from Zahar.
Yeah, so
Fail?
I'll try to find it.
Oh, I might not have got it.
I'll email it to you guys then. Okay, what email do you use?
Well, you get it?
I know. I don't have enough space. I'm not gonna buy another iPhone. No, you need to do this. This is the biggest thing in iPhone. Delete your memory. That's the one that was so much more. I don't even know what
Oh, your picture's stuck in your messages.
Well, because if you think about it, you're putting you have two different messages. Send double.
This is why Samsung.
Yes, because you don't have
Go
to
buy a little chip that
yeah.
is just quadruples your space. And then if you want to exchange it,
Because of the way that
take that one out, you put
iPhone
another one. The only thing I have to say that I was off is for resale value.
Like I said, downloading?
No questions yet.
I'll let you know.
Probably emails over the
Yeah,
weekend.
but if I go to solid,
Facebook right up.
that's all video?
Yes.
Oh, cool.
So, no, I didn't order pictures, but this is the problem. This is from that type program. Wrong name, wrong program, but my picture. Do I need to call them and make sure my picture that I mean, our board? Lori handed it to me and said, Lori, I didn't order pictures. And she goes, well, Lori, I did not order a picture.
Just call them or email.
And be like, listen, this is my name, you have the wrong, like, my picture's gonna end up on the back.
Somebody else.
I have a card.
I'm so sorry. Thanks for calling. Can I yell? Can I yell? Wait,
This semester is flying. It's unbelievable.
There's so much happening every
Yeah, storage is not your iCloud, it's your.
I know, and this week and last week was
Sandy was what sucked.
oh my god. I was losing. It's just stressful.
Yeah, it's not quite about
Oh.
I just went over because I felt like some visualizing. My dad, like, my dad has like, he realized,
That's totally got you right on the spot.
We need to. Yeah, we should. But tomorrow's supposed to be like
Really? We'll be past the chapter. It's like in the middle of something. This one is